Hi, everyone, and welcome to the Governor's Institute's Addiction Medicine Podcast. I'm Dr. David Ryan, the Clinical Assistant Professor with the East Carolina University Department of Psychiatry and Behavioral Medicine and the Department of OBGYN. I'm a board-certified physician in both OBGYN and addiction medicine. Today's episode is a talk I did for the North Carolina Family Physicians Alcohol Use Training webinar, When is Alcohol a Problem and What Can Be Done? We'll cover screening, diagnosis, and the neurobiology of addiction, along with the epidemiology, risks, and recommendations for alcohol use. We'll also take a look at FDA-approved treatments and available support networks to help patients in recovery. Thanks for listening in. Here's the presentation.
All right, well, welcome everybody. Thank you so much for attending. It's certainly a privilege and an honor to speak with you all today. And we're going to be talking about alcohol. When is it a problem and what can be done? There are no financial disclosures for this talk, and we will be discussing medications that are not necessarily FDA approved for the medical conditions that we're going to be treating. The objectives for both of these talks today is to understand how to screen for, how to diagnose, and understanding some of the neurobiology behind addiction. We're going to review the epidemiology of alcohol use and also alcohol use disorder, and we'll talk about different levels of intake regarding recommendations and risks. We'll analyze the 3 medications that are FDA approved to treat alcohol use disorder, and we'll also dive into the other mutual help or peer support networks that exist for individuals with alcohol use disorder. Just a little bit about me. I actually started my career as a OBGYN. That's me in the top left as a third-year medical student starting my career delivering babies. I did my residency at Chapel Hill from 2007 to 2011, and I was in private practice in Greenville, North Carolina for a little more than 9 years. I loved what I did. I thoroughly enjoyed private practice. I certainly do miss delivering babies and doing that part of obstetrical care, but I always felt particularly called to work with patients with substance use disorders. And after a few career changes, and I decided to reorient my career and study addiction medicine full time. I ended up going back to fellowship at UNC Chapel Hill in 2020, which was an interesting year for several reasons, but I did my addiction medicine fellowship there, learned an incredible amount, had a wonderful experience. From there, I actually spent a year working for Virginia Commonwealth University in their division of addiction medicine, doing both inpatient and outpatient addiction work. I spent a year at Walter B. Jones as a medical director, one of the 2 alcohol and drug treatment centers that are state-run in the state of North Carolina. And then in September of 2023, I was lucky enough to join ECU, Department of Psychiatry, and OBGYN to expand both the outpatient and the inpatient treatment options that we have for our patients with alcohol use disorder. However, the thing I'm most excited to talk about, or the thing I'm certainly most proud about, is that I'm a husband and a father. That is my wife, Sarah, and those are my 2 children, Jack, who is 13, and Catherine, who's 11. So we're going to start off this talk talking a little bit about the epidemiology and then the statistics regarding alcohol use and alcohol use disorder. So alcohol use is very, very common. Some of y'all might have expected me to start off with that. It's actually second only to caffeine as far as its modern day use and consumption for psychoactive substance ingestion. It's also one of the oldest psychoactive substances that have existed on the planet. Human beings have been essentially, quote unquote, tying one on since as long as we've been human beings. There's actually evidence of fermented beverages found in jugs that they can date as early as 10,000 BC, or certainly in certain villages in 7,000 BC. So it goes along, we have a long history of the human race in using alcohol. It's also incredibly expensive. It's estimated that it costs the economy almost $250 billion, or $250 billion every single year in direct economic cost. Due to loss or direct economic harm. Now, you can actually create a pretty interesting statistic. You can take that amount of money and you can divide it into the number of standard drinks that are ingested in this country every single year, and you come up with a statistic of $2.05, which means that we as a society incur $2.05 for every alcoholic beverage that's consumed in this country, or another way of saying that, as we as a society subsidize the use of alcohol to the tune of $2.05 for every glass of wine or bottle of beer. Now, I don't mention this statistic to make anybody feel bad about the beer they're going to have while they're watching March Madness, right, or their favorite basketball team, or the glass of wine that you have after a day of work. But I do want to point out that oftentimes one of the underlying assumptions when we deal with substance use or substance use disorders is that the ones that are really bad right? The ones that are super addictive or super harmful are the illegal ones that we kind of put over there. But the ones that are legal are probably the ones that are, maybe they're a little harmful or maybe they're a little dangerous, but they're overall okay. And I think a recurring theme that you're going to see in our talk is that not only is alcohol use incredibly prevalent, but alcohol use disorder is probably a lot more prevalent than you would expect. And also the damage that alcohol and alcohol use can do is probably going to be a lot more than one would anticipate. In fact, you can attribute almost 180,000 deaths every single year related to alcohol use and the downstream effects that happen from chronic excessive alcohol use. To put that number into perspective, we lose anywhere between 90 and 110,000 people every single year to unintentional overdose. The vast majority of that is due to opioids. The vast majority of that is due to synthetic opioids like fentanyl. And that gets a lot of attention, as it should. It's an incredibly sobering and sad statistic. But more people die of alcohol use every single year than die of unintentional drug overdose. And I don't think that that's talked about nearly as much. When you look at those deaths, about 2/3 of those deaths are from disease of quote unquote chronic use. So things that develop from long-term excessive use of alcohol, like cancer, heart disease, liver disease, et cetera. And about 1/3 of those deaths result from binge use or heavy episodic use. So if somebody were to use an excessive amount of alcohol and then would either die in a car accident or cause a death in a car accident, or they're combining different substances and they overdose, or suicides that occur because an individual is intoxicated and not thinking clearly. And those result in about 1/3 of the deaths every single year. When we talk about prevalence or how often alcohol is used, about 85% of individuals have used alcohol at some point in their lifetime, and almost 1 out of every 2 individuals has used alcohol in some form or quantity in the past month. The most recent statistics we have regarding traffic deaths is from 2021, where 31% of traffic deaths are attributable to alcohol use or misuse. And to put that number into perspective, that's about 1 person every 40 minutes. So in the time that it takes for us to complete these 2 talks, 4 people will have lost their lives in a car accident as a result of alcohol use. And again, it's associated with all sorts of chronic conditions: liver disease, cirrhosis, GI or throat cancers, heart disease, liver cancer, stroke, and one of the ones that we don't spend enough time talking about is its risk associated with breast cancer. And as an OBGYN who provides preventative care and has done so since 2011, that's something that I talk about frequently in my preventive care visits, as well as the risks of not only all these chronic diseases, but also breast cancer. So when we talk about heavy use, I think it's important to understand some generally accepted definitions. And when we talk about these numbers, we're talking about the numbers of standard drinks, and we're going to talk about what those definitions are later in this talk. And so when we talk about binge use, right, which means 1 episode of heavy alcohol use or binge use, right, or in one occasion, we're talking about 4 or more drinks for a female and 5 or more for a male. And when we're talking about heavy drinking, those definitions that we use are 8 or more drinks for a female in a given week, or 15 or more drinks per week for a male. So again, those numbers: 4 in any occasion for a female, 8 or more per week, and for men it's 5 or more per occasion, or 15 or more per week. And these are definitions that we've come across looking at a variety of studies, looking at outcomes. One of the things we're going to talk about in this talk as well is that any amount of alcohol is associated with some risk. But when we look at levels where the risk starts to increase exponentially, we see the risks start to dramatically increase when we hit these levels of alcohol use. So if we're going by these levels, which are generally accepted by the CDC or the NIAAA, it turns out that about almost 1 in 4, 24% of US adults have engaged in binge alcohol use in the last 30 days. So in the last 30 days, 1 out of 4 adults has exceeded the 4 or the 5 recommended standard drinks per occasion. 6% of US adults are engaging in heavy drinking or exceeding that 8 or 15 limits on the right side of the screen. And nearly all of the individuals that are engaging in heavy drinking are also engaging in binge alcohol use as well. And again, when we look at college-age kids engaging in binge alcohol use, it also reaches about 25% in the last 30 days. And again, what I was mentioning is that oftentimes, or at least one of the things I learned in medical school, which I feel like wasn't that long ago, but I guess was enough time ago, is I remember them telling you that about 50% of what you learn in medical school is going to be incorrect, except at the time you don't know what half is going to be wrong and what half is going to be right. And I do remember distinctly learning about alcohol use and learning about that J curve, which means that one standard drink was generally considered to be protective, but 2 or 3 a day, when you go outside of that, is when that exponentially, the risk level starts increasing. However, the World Health Organization in 2023 re-examined the data, and when you look at the data and you look at the individuals that were categorized as non-alcohol users, what they did not do in the initial study or the initial examination of that J curve is consider the reasons why people were put into the non-alcohol use category. And it turns out that a significant portion of the individuals who reported themselves as non-alcohol users did so because they either A, had underlying medical conditions, which caused them to not do so, which increased their likelihood of bad outcomes or death, or B, is that they did use alcohol, they ended up with some pretty serious complications from it, and then they stopped. And so when you consider that, when you consider people's alcoholic history, or you try to control for underlying disease processes, what you find is a direct correlation between risk and alcohol use. And again, this is something that we're going to be reteaching or trying to tear down probably for the next 20 or 30 years, is that it is accepted now that there is absolutely no level of alcohol consumption that is considered safe or beneficial. Meaning just like cigarette smoking, right? 5 is better than 10, 3 is better than 5, and 0 is better than 1. Turns out it's the same for alcohol as well. We've also had to come up with a new category of alcohol ingestion, which is this idea of high intensity drinking. So you double the amount of what we considered binge use, because individuals were reporting high intensity drinking or levels that were even excessively exceeding what we had come up with previous definitions to understand your binge alcohol use. So that would be 10 or more drinks for a male at a sitting, or 8 or more for a woman in one occasion. And when you examine individuals who are using alcohol in a high intensity fashion, the risks for bad outcomes are much higher. And the likelihood of ending up in an emergency department as a result of an injury suffered from alcohol use is up to 70 times higher for those that don't use any alcohol. And your risk of overdose injury, death, full blackout, or subsequently developing an alcohol use disorder are all significantly higher. So not only do we have to talk about binge alcohol use, but we also have to make sure that we're screening for high intensity alcohol use as well. So we've talked about alcohol use and we've talked about the prevalence of using alcohol, but let's talk a little bit about the prevalence of alcohol use disorder, or when someone crosses that threshold from high risk use, hazardous use into an alcohol use disorder, or a loss of control over consumption. And we are going to define an alcohol use disorder and how we screen for and assess for an alcohol use disorder later in this segment of the talk. But when we're talking about prevalence, some of the best data that we have comes from the NESARC-3, or a national epidemiologic study on alcohol-related illness that took place between 2012 and 2013. And it was certainly sponsored and it was self-reported. And what they found was that for a 12-month prevalence of alcohol use disorder, so at any given time in a 12-month period, about 14% of the people that were surveyed met criteria for an alcohol use disorder. However, if you extend that time period to an individual's lifetime, meaning asking all individuals at any point in their life if they had met criteria for an alcohol use disorder, that actually approaches close to 29%. So said in other ways, that almost 1 out of every 3 people are going to meet criteria for an alcohol use disorder at some point in their lifetime. And I don't know if that number sounds high to you, but that I've given this talk multiple times. I've talked about this statistic many times. It always alarms me and it always sounds high. And I've gone back and I've looked at different studies and I've looked at the changing incidence and prevalence or the data regarding it, and nothing has come out to refute this. Is that generally speaking, almost 1 out of every 3 people, or 29% of individuals, are going to meet criteria for an alcohol use disorder at some point in their life. Now, that doesn't mean severe. That could mean mild or moderate. And again, we'll talk a little bit about that. That also does not necessarily mean that it's not always active and people can reach periods of recovery or remission. But at some point in people's lives, 1 out of 3 are going to meet this criteria. When you parse down the epidemiologic data just a little bit more, you can see that certain categories have higher likelihoods of both annual and lifetime prevalence. At the top in the red is, again, those all population numbers. But we also find that men have a higher annual and lifetime prevalence risk. Men who identify themselves as white have a little bit higher of a lifetime prevalence risk, and when individuals identify as Native American, both their annual and lifetime prevalence risk is elevated compared to the entire population. There's a significant association of individuals who meet criteria for an alcohol use disorder and also have other substance use disorders, also meet criteria for major depressive disorder or bipolar 1, and there's an increased likelihood of antisocial or borderline personality disorder as well. This is an interesting statistic from the New York Times that looked at alcohol sales. You can see from 2016 also to 2024, there is an increase in the amount of alcohol that has been purchased every single month in this country. And first of all, the upward trend that is continuing on the quote-unquote pre-pandemic trend is still pretty alarming how often it is increasing. But you can see in the pandemic, we know that the pandemic had a lot of awful effects, both long-term and short-term, both economic, mental health, but certainly in the substance use disorder space, it was not spared. Patients with substance use disorders faced a whole bunch of negative consequences and outcomes. You see this risk with overdose deaths as well, but you can see how alcohol sales dramatically increase. And they have trended down since 2022, but have only reached that pre-pandemic level upward trend. So it's still dramatically increased from where it was in February of 2020, and unfortunately, sales continue to rise on this upward trend. During the pandemic, up to 10 to 20% of individuals increased their alcohol use. There was one more day per month where 75% of adults were using alcohol more. And for women, 41% noted an increase in heavy alcohol use. So who is at risk? We've talked about alcohol use. We've talked about some of the statistics regarding alcohol use and its consumption. Who is at risk for developing an alcohol use disorder? And when we talk about risks for addiction, there's a lot of different contributing factors to it. So the first, and this is not meant to be an inclusive list, but this is meant to be some of the ones that are most common and things that I want to make sure that you're familiar with. First of all, the brain circuits, which we are going to talk about in a few slides, how they can be rewired when mind-altering and mood-altering substances like alcohol are introduced into the system. If there's a personal history of addiction, oftentimes individuals are more likely to develop another use disorder. Genetics and the family history of addiction plays a very large component. We think anywhere between 40 and 60% of addiction is related to genetics. And with the environment that an individual finds themselves in, whether there's current substance use, whether their peers are using it around them, chronic instability or chronic stress, all of this we know plays a role. And then also life experiences or things that happen to an individual early in their life, like the ACE score. And I do want to spend a couple slides talking about the ACE score and the way it can contribute to an individual's risk of developing an addiction or a use disorder. So for those of you that are not familiar with ACEs, or adverse childhood experiences, in the mid-90s, Kaiser Permanente, a very large insurance conglomerate in the western part of the country, sent out a survey to about 17,000 patients that underwent a physical exam in their institution, and they got about 15,000 back, which is pretty remarkable. And they were asking these individuals about their exposure to ACEs, and they defined ACEs as an adverse childhood experience or something that happened to an individual in the first 18 years of their life. And they defined them in three different categories. The first is abuse, physical, emotional, or sexual abuse, but then they also define this idea of emotional or physical neglect. And then they asked them if there were signs of household dysfunctions, right? Was there mental illness in the home? Was the mother treated violently? Was there divorce? Was somebody incarcerated, or was there active substance use in the home? And you could see how those things, if they were occurring to a child at 5, 6, or 7 years old, if they were experiencing those, how that might contribute to chronic stress or chronic instability in the home. And they wanted to see if they could correlate ACEs with, well, a lot of things, with medical conditions, but also substance use and substance use disorders. And what they found was not only can you correlate the number of ACEs an individual experienced in their childhood with multiple chronic diseases like diabetes, obesity, hypertension, and stroke, but there is actually direct correlation between the number of ACEs that an individual experienced in their lifetime, and then if they considered themselves an alcoholic, had ever used illicit substances, or ever injected drugs, to the point where if an individual had been exposed to 4 or more of those ACEs growing up, they were 10 times more likely to have ever injected drugs compared to somebody who had no ACEs. And this was this continues to be very helpful and eye-opening reality for me, or study for me, because oftentimes when you're dealing with patients or talking with patients with substance use disorders, especially when they're in the throes of active withdrawal, or especially when they're in the throes of their active addiction, right? And their executive function is impaired. They're not able to weigh risks and benefits like somebody who is unaffected is. It can sometimes, I'll use a word, it can be frustrating, right? It can be challenging. And this is a very helpful slide for me, because I realized, or what this slide tells me, is that people didn't do things to my patients when they were 5, 6, or 7 years old, they probably wouldn't have an addiction. Meaning if my patients weren't beaten, right? If they weren't sexually abused, if their mother wasn't beaten in front of them, right? If there wasn't active substance use in the home, if their father or their mother wasn't arrested because of a variety of reasons, including substance use. Like if these things didn't happen to people when they were 5 or 6 or 7 years old, when they had absolutely no control over anything in their life, what this tells me is that they probably wouldn't have an addiction, right? They actually probably would have a completely different life, but because things that people did to them when they were young and they had no control over, it set them up to be sitting in front of me. And I always find it particularly helpful to keep that in mind, especially when I'm having a challenging interaction, to help me put it into perspective. So we've talked about the risks of addiction. Let's talk about how we're going to screen individuals for harmful or hazardous alcohol use or alcohol use disorder. And the USPSTF recommends that all patients in primary care, including patients who are pregnant, should be screened to identify unhealthy alcohol use. At the top there, we have the CAGE, we have the audit, we have the audit C. These were particularly studied in primary care and for alcohol ingestion only. But you can also see there's a litany of other screening tests. And this slide is not meant to be inclusive. In fact, it's meant to be a little bit overwhelming, because there are a multitude of different ways and a multitude of different tools that have been studied and have been validated to screen for unhealthy substance use and unhealthy alcohol use. The audit and the audit C are here for you to see. The audit is a little bit more extensive. It talks not only about amounts of alcohol ingested, but also feelings around alcohol, loss of control, consequences regarding alcohol, the way alcohol might be interfering with an individual's life. And that's going to hit more on those criteria for substance use disorders, which we're going to talk about. The audit C is a little bit simpler. It's obviously parsed down. It's only 3 questions. And it focuses mostly on amounts, which is going to help you ascertain a little bit more about individuals' risk regarding their use, and also open up the door for more screening. And so when you look at all of the screening, or what's available, at the bottom here you can see the sensitivities and the specificities for unhealthy use versus alcohol dependence. Now, alcohol dependence is a DSM-4 criteria. We've revamped those criteria to talk about DSM-5, so we talk about alcohol use disorder, but there's relative overlap in both of these things. And you can see how you have different specificities and different sensitivities for different questions, and you can really go down a rabbit hole if you want, and you can get lost, and you can get paralysis by analysis looking at trying to find the most perfect screening tool for exactly your patient population, and individuals end up doing nothing because it becomes so overwhelming. So really my key takeaway when we're talking about screening for alcohol use or alcohol use disorders is just ask something. Everything is okay, some are good, some are not so great, but it doesn't really matter if you have the perfect tool if you don't use it, right? The best tool is going to be the one that you're going to be able to use and incorporate into your practice in some way, shape, or form, so you can end up having conversations with patients and identify unhealthy alcohol use. This is an example of what I use when I'm doing my alcohol use, when I do my GYN physical exams. It is a sequential audit, so it's kind of a combination between the audit and the audit C. And basically you ask an individual, and again, this is tailored to women or females, because at the top there, how many times in the past year you had more than 4 drinks. So if you were doing it for a male, it would be 5 or more. And then if the answer is 0, an individual screens out. But if they answer yes to or more than 0, then you ask the first 3 questions and you score it depending on what the result is. And if it's greater than 3, then you ask all the questions. And for me, I put the results down there so I don't have to look up what a 8 versus a 16 versus a 4 means. I can kind of see it right there for myself. And this has worked pretty well. And I might assume what some of you were thinking is, well, what if your patients lie? And that is one of the challenges with screening, but also one of the ways in which we can create a non-judgmental environment that we should strive to, so patients feel like they can be honest with their answers and they can feel like they can talk about their issues without being judged. And I would say that probably about once every couple weeks, I have somebody screen positive for the audit sequential, and it allows me to have a conversation. So patients will answer this honestly if they feel like you're not going to judge them, or they feel like their results are going to be confidential, or that it's going to lead to a conversation. And again, so the screen is positive. Now what? And what I don't want to have happen is for everybody to feel like they're a deer in headlights. And that used to always bother me whenever, I was doing a conversation or whatever. I'd go to a talk and everybody would talk about the screening test. Well, then nobody would talk about what you do with a positive screening test. Everybody would talk about the importance of screening, but then nobody would talk about what the next step was. And I never really particularly appreciated that, because it's really not, you should be screening, but it's really not helpful if A, you don't look at the screening results, or B, you don't know what to do with the positive results. So let's talk a little bit about, now that I've recommended that you screen, that you pick something, and that you screen for alcohol use and alcohol use disorder, well, what do we do about that? And then so we've hit the screen, or the S, when we're talking about the SBIRT, so let's talk a little bit about brief intervention. And there are ways in which we, in the addiction medicine space, engage with patients in order to create an environment in which they feel like they can tell us what's going on and talk to us about their alcohol use. There's some overlying themes that we use. Motivational interviewing, if it's not something that you are familiar with. I was 40 years old and a fellow when I learned about what motivational interviewing is. So if you've been practicing medicine for some time and motivational interviewing is maybe something you've heard of, but you're not familiar with, or you've never heard of, there's certainly no shame in that. And I certainly encourage you to look into that and to avail yourself of all the resources regarding motivational interviewing, because at the very least, it's a more efficient and productive way to talk to patients. And honestly, it actually leads to more pleasant interactions. My take on intervening for alcohol use or any kind of unhealthy substance use or any unhealthy behavior was to provide information to a patient and then expect things to happen. And that never resulted in change. And that can be a very frustrating way to deliver care. It can be very frustrating to not feel like you're making an impact. But when you're engaging in these techniques, it actually gives you tools with which to guide a conversation so you actually feel like you're being impactful. And studies will show that you are being when you engage in these. So very, very briefly, when we give feedback, or when I give my patients feedback on their substance use, I'm always asking their permission. Is it okay if I talk to you about some of the risks involved, or to make sure that you're aware of some of the risks that come with your level of ingestion or with your ingestion of this certain substance? Talking a little bit about again, the responsibilities that patients are ultimately the experts in their own lives, and where and if and when they decide to make changes, kind of figuring out their reasons and supporting their own desire to change is really going to be more productive. I would give advice and always predicate that with asking for permission. Saying, as your physician, it's my job to offer you medical advice regarding your substance use. Is it okay if I give you some thoughts? Providing a menu of different options for patients, whether that be medication or different peer support groups that we're going to talk about. And always with the idea of empathy, right? Which again is something that I know you all have. If you're physicians and you're providers, you did not join the profession of medicine because you lacked empathy or a desire to improve patients' lives. I know that's a very just innate part of who we are and what we do, but it's always worth remembering, especially when we're looking at the clock and the 15-minute encounter is now running into 16 or 17 minutes, or the patient is late, or they're not able to adhere to our treatment recommendations at this point, is always to remember to try to put ourselves in the patient's shoes, or at least to think about it from their perspective, and enable us to just continue to reflect and be empathetic and to try to be understanding, to approach things with a genuine curiosity, ultimately keeps that therapeutic relationship strong and will ultimately lead to better effects. And then the idea of self-efficacy, right? The idea that a patient has the ability to make changes in their own lives. Oftentimes I've found that my patients with substance use disorders have very low self-efficacy because of consequences they've encountered, because of traumatic experiences or abuse that they've had, because of their negative interactions with the healthcare system, is oftentimes they don't feel like they have the ability to make the changes that we're recommending. And finding ways to support a patient's idea or self-efficacy can be very, very helpful. So does it work? And the short answer is, yeah, it does. In 2012, they did a meta-analysis of 23 trials that looked at brief interventions, and it did lead to some positive outcomes. About 3 for most patients. Consumption decreased by about 3.5 standard drinks per week. 12% of individuals had fewer drinking episodes, and about 11% of individuals increased the likelihood that they were going to drink less than the recommended limits. So there was 3 areas where there were real positive changes. Now, and sometimes I think it's also important to remember that abstinence oftentimes is our patient's goal. And yes, from a absolute risk standpoint, as I said, 0 is better than 1 and 2 is better than 5. But if we can get an individual from like 10 standard drinks a week to 5, or we can get individuals from high intensity to just below those levels of heavy or binge use, there are positive outcomes associated with that. A lot of times in the United States, when we look at trials versus medications, abstinence is the primary outcome. But there's a lot of really good data, for example, from Europe, that shows that just by decreasing the levels, right, or the amount of alcohol ingested, outcomes do improve. So even if abstinence isn't necessarily achieved, we do know that less alcohol use, as far as a risk reduction model, does improve outcomes. But it's important to understand that brief interventions do not affect the levels of consumption for individuals with an alcohol use disorder, previously what we called alcohol dependence. So if an individual has harmful alcohol use or hazardous alcohol use or heavy alcohol use, if you perform a brief intervention, they're going to end up using less alcohol. However, if an individual has an alcohol use disorder or an alcohol addiction, that is not going to affect the level of consumption. And oftentimes that can be very frustrating. Right? Our initial gut reaction is to say, oh, well, it didn't work, or why isn't it working, or what's wrong with you? Well, it actually should give us a moment of pause. Because if we're identifying individuals with an addiction, one of the primary features of addiction is continued consumption despite consequences. So this is an individual who might say, I am aware of all the risks, I don't want to be using alcohol this much, I understand all the benefits to it, but when push comes to shove, I'm not able to stop. So if you do a brief intervention, and you have decreased alcohol use, great. But if you do one and nothing changes, instead of getting frustrated, maybe that gives you a moment of pause to say, well, wait a minute, maybe my patient is actually diagnosed with a use disorder. So some of the other signs of a use disorder, maybe concerning signs of substance use or misuse. So early refill requests, especially for controlled substances, if they're just lost or just one time. Now again, things happen. Yes, people do actually lose prescriptions. Yes, they do get taken from them. Yes, the dog eats the homework sometimes, right? But if it's every month, a couple times a week, multiple times a year, that might give you a moment of pause and try to wonder if maybe something else is going on, especially if they ask for an additional controlled substance. And again, I'm not trying to stigmatize or paint with a broad brush. Some people might be asking for another controlled substance or another prescription because their symptoms are not controlled, right? Their anxiety or depression is not controlled, but it should also be on your differential about concerns regarding a use disorder. If there's an acute decline in mental or physical health, use disorder might need to be part of that as well. Change in habits, change in sleep, consequences, infections that you don't typically find outside of a substance use, like endocarditis or abscesses. A positive toxicology screening for other substances. Now, it's very important to understand that a urine toxicology test does not screen for, nor does it diagnose a substance use disorder. It doesn't tell you about that individual's relationship with that substance or the consequences that an individual is having as a result of that substance. Just like there are plenty of people that use alcohol and do not have substance use disorders, there are people that use illicit substances recreationally that do not necessarily have a use disorder. However, if a substance is found on a urine toxicology screen, the likelihood of having a use disorder is higher, and that might be something that you want to address. If there are new legal issues, if there's a decline in some performance or a decline in a relationship, those can also be signs that would make you attuned to or try to be aware of a use disorder. So how are we diagnosing a use disorder? How do we understand, what happens when somebody crosses over from maybe hazardous use over to a use disorder? Well, I really appreciate the definition of addiction by the American Society of Addiction Medicine. This is not a diagnostic criteria, but this is simply a summation that the American Society of Addiction Medicine has done regarding addiction as a whole. And I'm going to do the thing that you're not supposed to do in a presentation, which is to read off the slide, again, because I think that this definition is so just rich and really full of a lot of really important information. In fact, when I give lectures to medical students about addiction, We spend an hour actually on this definition, just dissecting every word. I'm not going to put you all through that. But one of the first words that the American Society of Addiction Medicine, or ASAM, uses to describe addiction is treatable. And I think that that's wonderful. And addiction is treatable, chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. And again, there's so much in there. The last sentence there, understanding that the treatments that we have are considered generally as effective as the treatments we have for other chronic conditions like diabetes, hypertension, and asthma, right? Which is really good news that they work as well as they do. Understanding that addiction is chronic, but it's also treatable. It's something that an individual will have as pertinent to their history throughout their life, just like asthma, hypertension, or diabetes can be, but also that there are interventions that we can offer. But the thing I want to bring your attention to right now is that middle portion right there, or understanding that one of the primary features of addiction is this idea of continued use despite harmful consequences, right? That oftentimes we recognize that as one of the most frustrating aspects of taking care of patients or addiction, but we don't really realize is that we're identifying a use disorder potentially, right? When we inform individuals about risks, when they express a desire to stop, but they're unable to do so, that is indicative of an addiction, meaning that the use has gone outside of an individual's ability to choose or a control over the amount that they use. I use smoking as one of my favorite examples because, as I said, before when I was a provider, I would provide information and I would expect that to lead to behavior change. And when it wouldn't, I would just provide more information. And when I have a patient, for example, who smoked cigarettes, I never had a patient look at me when I told them that smoking was bad for them. I never had a patient look at me and say, Dr. Ryan, no one has ever told me that smoking was bad for me. I had no idea that this was harmful. Thank you so much for providing me with this information, as they give me a high five as they walk out the door and throw the cigarettes in the trash, never to smoke again. Right? If that was it, if all I needed to do was provide information, I wouldn't have a job and there would be no addiction medicine field, right? But when I create an environment where my patients can tell me, and perhaps you've experienced this too, they'll look at you and they'll say, I know, I don't want to smoke. I hate smoking. I know it's bad for me. My father died of lung cancer and I'm worried that's going to happen to me. It's expensive, makes my clothes stink. I can't taste foods. My kids hate it. My spouse hates it. Like they'll give you all of these reasons why they don't want to smoke, but when push comes to shove, they're not able to do so. And that is because of the neurobiological changes that underlie the pathologic process of addiction. When we diagnose addiction, we look at these criteria from the DSM-5. And what you'll find is, and this is not the way that they're listed in the DSM-5, but when we're going to diagnose a use disorder, and what's very convenient is that this diagnosis of a use disorder is the same for every substance, right? Whether that be cocaine, methamphetamine, opioids, or alcohol. But I've lumped them to this because there's 3 different themes that you're going to notice. And if people have 2 or more of these in a 12-month period with some impairment or distress, then they meet criteria for a use disorder. And the more that you have, the more severe the use disorder is. So if you have 2 or 3 of these in the last 12 months with significant impairment or distress, you have a mild disorder. If you have 4 to 5, it's moderate. And if you have 6 or more, it's severe. But what you can see is this underlying theory of this craving, right, this physical compulsion to use associated with tolerance, withdrawal, or desire to use. And then there's this idea of consequences, things happening in an individual's life that are negative. They can't meet obligations, their relationships are strained, they've given up activities that used to be fun. It's physically harming them, it's physically harming other people, like getting in a car and driving. It's psychologically harming them, like making their insomnia and their anxiety worse, but they're continuing to use. And then there's this loss of control. They use more than they want to. They've tried to cut down and they're not able to. And when they they find themselves using more and more frequently and spending more time using. And then, so when I'm ascertaining for a use disorder, I kind of use, it's called the 3 C's. It's like, is there craving for use? Is there physical signs of a dependence? Are there consequences from continued use, or is there a loss of control? And then finally, if we've done that brief intervention and we've informed people of their risks, then we talk about referring to treatment. And this is where, unfortunately, I don't have a lot of information to offer because it's going to depend on what area that you live in. But you want to find either colleagues or specialists in your health system or in your area who are addiction medicine certified or addiction psychiatry who are taking patients, but also potentially starting some treatment yourself, which is going to be what we focus mostly on in the second talk. So very briefly, I want you to understand the neurobiology of addiction, or the underlying neurobiological changes that cause some of the behaviors that we see. And there are many different neurological mechanisms that underlie addiction, but what I'm going to focus right now is on the nucleus accumbens, or the motivation pathway. This is in the limbic system of our brain, or the primitive part of our brain, or the quote unquote subconscious part of our brain, right, which controls impulses and dictates behaviors in ways that we're not necessarily aware of. And this is a part of the brain that gets dopamine surge to it when the body or the brain engages in an activity that the brain has said is important for survival. So 50,000 years ago, if we were running around in the woods, we came across a blueberry bush, you ate blueberries, they were sweet, they were delicious. It raised dopamine in the nucleus accumbens because your brain wants you to engage in this activity because it's healthy. Being around other people raises dopamine in the nucleus accumbens because when you're around other people, you're safe. 50,000 years ago, if you were by yourself, you were getting eaten by the bear. Sex is a really good way to raise dopamine in the nucleus accumbens. What could be more important for the survival of the species than finding a mate and engaging in that activity? So none of this stuff is bad, right? Dopamine gets a pretty bad rap nowadays because of our quote unquote screen addictions or internet addictions. But dopamine is very important to get us to engage in these activities. But the problem is that we have 21st century chemistry that has encountered 100 million year old neurobiology, and unfortunately it is ill-equipped and it is being taken over. And the word that I actually use is hijacked. So the substances that we can put into our brains today raise dopamine in the nucleus accumbens higher than what normal physiologic activities will do. For example, methamphetamine will raise dopamine in the nucleus accumbens 5 times higher than what sex will do. And this system starts getting taken over. And on a subconscious level, right, the reasons for using substances are oftentimes very different for the reasons why people continue using them. But when they use them, on the subconscious level, the brain is being told that this is an activity that's important for survival and should continue. And when we use chronic use of these substances that increase dopamine, we absolutely flood this center. And we do not know why. For some people it's alcohol, for some people it's opioids, for some people it's cocaine, for a lot of people it's tobacco, for some people it's none of these things, right? We don't necessarily understand all of the underlying pathophysiology. But when dopamine starts surging in this area, the receptors start down-regulating because they don't like being screamed at, so it starts adapting. The brain will adapt to it. And what does that end up looking like? Well, now you need to use more of that substance to get the same level of dopaminergic stimulation. The unfortunate flip side to that coin is that activities that used to be stimulating, that used to increase dopamine, like doing a good job, hanging out with your spouse, spending time with your kids, whatever hobbies that you were doing, no longer even register on the scale. So you have to use more and more of the substance to get the same effect, and other things that used to be rewarding are no longer so, which is why an individual might start off using alcohol once a week, then 6 months later, maybe it's every day, and then a year later, they've lost their job, they've lost their spouse, they've lost their home, and they look up and they don't know what's happened. Because on a subconscious level, the brain was being told it's important for survival. When we talk about standard drink sizes, this can be a really, really helpful thing to understand. When an individual is using standard drinks, when we talk about the drinks and the levels that I was talking about, what we talk about is 12 ounces of beer is equal to about 8 ounces of malt liquor, is equal to about 5 ounces of wine or 1.5 ounces of a distilled spirits or liquor. And over there to the right are the common quantities that alcohol can be purchased in. A pint, a fifth, a liter, and a handle. And those are the amount of standard drinks that each of those containers holds. It's worth remembering these or memorizing these, so when an individual tells you about their alcohol use, you can kind of use some shorthand to do some quick math to understand exactly what it is that individuals are ingesting. So when we're talking about how much individuals use, right, they're going to tell you not much. And so first of all, you want to clarify the type and the amount that individuals are using, especially beer, because oftentimes they might call malt liquor beer, and you can see how a can of beer versus a 40-ounce can of malt liquor can be very, very different. And I often find it's very useful to ask about the frequency and the quantity of the distilled liquid purchases, meaning people aren't going to tell you that you use 6 ounces of vodka a day, but what they might tell you is that they buy their vodka in a handle, and that lasts them anywhere between 3 or 4 days. So again, with some quick math, you can kind of figure out the alcohol levels that people are using. We're going to talk very briefly about the pharmacokinetics and dynamics of alcohol use as we're closing this talk. Alcohol is metabolized in the body to acetaldehyde and then into acetate. through those enzymes listed above. There's a little bit of alcohol metabolism that occurs through the CYP2E1 system. And it's also understood that it's what's called zero-order kinetics, meaning at a certain point, individuals will only remove a certain amount of alcohol from their system per hour, so about 1 standard drink per hour. So if you use 6 standard drinks, it's going to take about 6 hours to completely get rid of the alcohol in the system. Alcohol is a positive allosteric modulator of GABA and a negative allosteric modulator of the NMDA receptor. It interacts with a variety of channels, but essentially it increases the inhibitory effect of GABA and decreases the excitatory effect of glutamate. So it's overall an inhibitor, a CNS depressant. With chronic use, the body will compensate for this by decreasing the number of GABA receptors and also, increasing the receptor sensitivity of GABA and increasing the glutamate receptor numbers. So it compensates for the alcohol, so the receptor to GABA isn't as sensitive to GABA because the ethanol is helping out, and the NMD receptors increase because the ethanol is blocking some of those receptors. Just so you're aware, these are some of the effects at different levels of alcohol, 0.08% or 80, depending on what your test units are using, is the legal limit here in North Carolina, also for driving. And this is where an individual will have some impaired reasoning and reduced muscle coordination. So what does chronic alcohol use look like? I told you there with GABA, when the ethanol comes in, it enhances GABA, it inhibits NMDA, which leads to neural inhibition. Well, with chronic use, GABA receptor sensitivity decreases due to the increased effect from ethanol, and NMDA receptors increase to counteract that antagonism. And this is how the system balances itself out. And this is why with chronic alcohol use, somebody can walk in with a level of 300 or 400 and be carrying on a conversation like I am because their body compensates for that. And that's all well and good until the ethanol is removed, because maybe they run out of money, maybe they've decided to stop, or maybe they get admitted to the hospital for another reason, they don't have access to their ethanol. And because neurons take time to remodulate and reconfigure themselves, what you now have is not enough GABA and too much NMDA, and this is what causes withdrawal. This is why you see withdrawal, this is why you see seizures, and this is why you see delirium tremens. About 90% of individuals are going to have a mild alcohol withdrawal when they stop, between 6 and 24 hours, which shows like a little tachycardia, sweating, flushing. It's transient and passes in about 1 or 2 days, but about 10% of individuals are going to meet criteria for severe withdrawal, which can present with seizures as early as 8 hours after the last use of alcohol, alcoholic hallucinosis or isolated hallucinations 1 to 3 days later, or delirium tremens that present anywhere between 2 and 4 days later. So something to keep in mind is sometimes the most severe form of alcohol withdrawal, or delirium tremens, does not present for 2 days since the last alcohol use. So it's an important clinical picture to keep in mind. 90% of individuals that use alcohol, quote unquote, excessively are not going to develop dependence, meaning they're not going to have a severe withdrawal syndrome. We don't really know, again, because there's a lot of polymorphisms regarding metabolism or tolerances, but what we think is about 4 or 5 standard drinks per day, or that upper limit of heavy use, every day for about a month will lead to some sort of dependence or withdrawal. Finally, as we are ending this part of our talk 1, when we're looking at biomarkers for alcohol use in the urine, we can test for something called ETG, which has a high false positive rate, but it looks at alcohol ingestion from the last 1 to 5 days. You can send a reflexive ETS for confirmation. In the blood, there's several different levels that we look at. The PEth, the GGT, and the LFTs can be affected, in addition to the MCV also being altered.
Thank you for listening to part 1 of this virtual training on alcohol use. When is it a problem and what can be done? If you like this content, check out more episodes of the Governor's Institute's Addiction Medicine podcast. You can find it on all pod platforms. And for more training opportunities, including the Governor's Institute's spring, summer, and fall conferences, go to addiction-medicine.org. Have a great day.